Hello to everyone and welcome to the Winter 2016 session of the NAPSA NICP Research to Practice webinar series. This is sponsored by the National Adult Protective Services Association, National Committee for the Prevention of Elder Abuse, and the National Council on Crime and Delinquency, all of whose logos you should see on your screen. My name is Andrew Capehart. I'm the Assistant Director of the National Adult Protective Services Association, and I'm your webinar moderator for today. Today, Linda Kincaid with the County of Ventura in California will present on advancing the field of APS through research, an introduction to the tool for risk interventions and outcomes, or the TRIO. Before we introduce Linda and get started with our presentation, just a few little housekeeping issues. If you experience any audio problems during the webinar, we suggest hanging up and dialing back in again. Unfortunately, we have a lot of folks on the line and we have limited capacity to troubleshoot audio related difficulties during the webinar. If you find that you can't resolve your issue at all, we want to let you know that you will be able to view a recording of the webinar at a later date, estimate about 2 weeks after the webinar is complete. And we'll be sending notice to everyone who registered for this webinar about that when it goes up, and there'll be links on the NCCD and the NAPSA website to those. At any time during the presentation, please type in your questions and comments in the question box on your attendee control panel, which you'll see a little sample of here on the screen. I will present your questions to Linda, our speaker, and at the end of the webinar, we'll do our best to get to everybody's questions, although we'll also pause every now and again throughout the presentation to take questions. And then I think it's my pleasure to introduce today's presenter. Linda Henderson is a licensed clinical social worker and a certified addiction specialist. Linda's career spans 44 years in public and private sectors with expertise in both healthcare and social service settings. Serving vulnerable populations for all of her career, Linda is the former director of the Child Welfare System and Public Health Department of Ventura County. Currently, Linda is dedicated to designing methods to improve client outcomes, teaching and training on various topics, with the desire to work with other committed individuals to advance the field of APS. And Linda is an excellent presenter. I know that she's presented at the annual NAPSA conference for us for several years now, and we are very, very happy to have her on today's webinar. And so, Linda, I'm going to turn the screen over to you and make you the presenter. So you should have a little box that pops up whenever you're ready to accept that and share your screen, and then we should be able to see your screen and take it from there.
Okay. Screen there?
There you go. I think we
thank you.
It, yeah.
Okay, very good. Well, thank you. Welcome to all of you around the nation. Thank you, Andy and Carol, and much appreciation to NCCD and NCPEA for sponsoring this Advancing the Field of APS through Research and an introduction to the TRIO. Such a delight to be with all of you. My partner, Dr. David Sommerfeld, who did the research on the TRIO in 2009 to 2011. So the data that I'm going to be sharing comes from the work that David did in conjunction with us here in Ventura County. So he's with us in spirit. So, advance it. So our work began in 2008 when we began to recognize, as many of you did, that the changing demographics of the United States and actually the world was having a huge effect on APS. So we see people getting older, the boomers, seeing the increasing prevalence rate of cognitive impairment in our population. Since we do a MOCA on every client of ours 65 and older, we have about a 22% of our clients served in APS who have moderate to severe cognitive impairment. People are living longer. You know, you read about this in the paper all the time, people living into their 90s and living into their hundreds. And so what this has done to us is increased our referrals to APS and increased our caseloads. This has happened in Ventura, and as I talk to people around the United States, this is happening to lots of you. And when you have more clients coming in and funding begins to get squeezed, you have a heightened sense of accountability. Funders, your boards of supervisors want to know what you're doing and how you're doing it and what are you achieving. So we have more accountability in our system than ever before, and actually that's a very, very good thing. And the other thing that we recognized in 2008 and continues is kind of this lack of a standardized approach that leads to better outcomes. And we know that in any complex system, whether it's APS or child welfare or healthcare or aviation or manufacturing, all of those systems have something in common, which means they are complex systems. They have multiple interlocking interplays of many components: people, systems, environments, economy, all kinds of things making the system a complex system. When you have a complex system, standardizing your approach and having consistency improves the outcomes. That is just an absolute truth about complex systems. We also discovered in 2008 that there's really limited research on who are the clients being served in APS and how is that connected to the interventions we provide and the outcomes that we get. So lots of research describing clients who come into our system, perhaps some research on who the clients are, but how that profile, I'm going to call it a profile, what those clients look like, and how that relates to the interventions we provide, and then what is the ultimate outcome. There was kind of a dearth. And then what APS is really, really good at is focusing on measuring process objectives. So we're really good at counting things, and counting things are very important. You need to count how many referrals, how many cases for each client, how many financial abuse, how many self-neglect, time frames, what's the percentage of time we meet our mandated time frames according to your state laws. So those are process objectives. Those are very important in describing the work, very important in understanding the flow of the work. But what the missing link is this comprehensive framework for measuring a process to provide guidance to social workers, ensuring that there's consistency among the team, which leads to better outcomes for clients served. So that was the missing link, which is a measurement beyond process measurements. So our mission in 2008 when we started this was to design a tool based on social work practice. So APS, in my opinion, is the closest program to social work practice, closer than child welfare. It is the closest to traditional social work practice. So therefore, we designed a tool based on social work, established social work practice. So first of all, the tool is based on standardizing the approach to investigation assessment, having a consistent approach. So one thing we did with the TRIO was, by improving consistency, was to agree on terminology. We wanted to make sure that if one social worker said there's conflict in this family, and another social worker said there's conflict in this family, we all knew what conflict meant. So as conflict means the day-to-day squabbles that occur in families, or is it conflict that rises to the detriment to health and well-being and stability to the client? So that's how we define conflict, and that's how we define it in the TRIO. So having agreed upon terminology and consistency improves your outcomes. So we also wanted to design a tool that would guide the practice, not dictate the practice. We wanted a tool that would help document the work so that the social worker didn't have to double document. So they would document their risks and interventions and outcomes in the TRIO, and then in their case notes narrate and document supporting evidence of why they selected a particular risk indicator. And then we wanted a tool that would measure both the client outcome, health, stability, and well-being, and measure the program outcome. Did we fix the problem or not? So two key things when it comes to the TRIO is we wanted to answer the question: when we respond, do we actually change lives? And can we measure that? And I think as I go through the presentation today, I think you'll see that the TRIO is quite good at answering that question: when we respond, Do we change lives, and do we make a difference? And the second thing the TRIO does is, because many times when the referral comes in, we have a window of opportunity because we may never have a chance to see that client again. We want to make sure that during this window of opportunity, we do the right intervention, that we select the intervention that is most appropriate for the risks indicated. We do it at that time, and we have a goal in mind. So we are always, whenever we knock on the door, we want to eliminate the risk. If we can't eliminate the risk, can we mitigate the risk? Can we reduce the risk to the client? We also measure whether or not we can't solve the problem and it goes unresolved. So key to this is, do we make a difference, the right intervention at the right time for the right reason? So the design of the TRIO was designed by social workers for social workers, which I think is very important in adult protective services. And it's based on established history of best practices and evidence-based practices in social work practice, which is taught in all MSW schools around the nation. First of all, the TRIO is based on a biopsychosocial approach that social workers assess and investigate, looking at the interplay between the biology of the client, the psychology of the client, and the social domains of the client and that family. Secondly, we always want to measure a goal. We want to have, what is the goal in mind? And our goal is always to fix the problem or reduce the risk. But more importantly, we want to measure progress, because not every time can we make a huge difference in eliminating the problem, but we want to make incremental progress towards. Every system, healthcare does this. Healthcare measures progress towards improving the lives of people or curing disease. And because our clients, those who do have capacity, oftentimes have to go through a contemplation stage of making that change, measuring progress is as essential as measuring the goal of fixing the problem or not. The next thing the TRIO does, which is established social work practice, is it allows the social worker to look at how well the person and the environment that they're living in fits. Does the environment support the person's needs? And if not, what are the interventions that need to be provided to narrow that? Because what we often find in our work is that the environment is not able to support the client's needs at the time. They shouldn't be living alone. They're living in a high-risk situation, and that environment is no longer appropriate. The next thing I want to point out when I show this is this issue of scoring versus cluster. And I get asked about this all the time. This is a great question. The TRIO does not use a scoring system, point system, does not use high, medium, low. The scoring systems is an excellent model for tools when you don't know what you have. So I don't know if I have cognitive impairment. I don't know if this is alcohol abuse or not. I don't know if this is depression. Tools like the Beck Depression or the MoCA, the MMSE, or any other tools that you all use to try to ascertain the actual underlying problem of the risk. Scoring tools are excellent. They will give you a point spread. They'll tell you if you do have an alcohol issue or not. It will tell you if you have cognitive impairment or not. So scoring is excellent. The TRIO doesn't use a scoring system. The TRIO looks at the cluster of risks that forms a profile and then relies on social work expertise, judgment, experience to triage what part of that cluster needs attention first, second, and third, so it kind of triages it. The other thing that comes to that I get calls about all the time is when systems are trying to transform their system, they're trying to find a single model or tool to do that. The TRIO will not do that. The TRIO is one component of a comprehensive APS system, which includes regularly scheduled supervision, regularly scheduled MDTs, multidisciplinary teams, having an integrated medical social approach whether you have social workers or neuropsychologists on your team, or whether you contract or you have a system that's highly integrated, is absolutely valuable, and I'll show you some data to support that. Ongoing training on investigation assessment, and very important, ongoing training on understanding APS or social work bias that can creep into the work, what we used to call countertransference, or what we bring to the table, our own biases that need to be constantly talked about and checked so it doesn't contaminate the work. The need to do curbside consulting, where a social worker has an issue that comes up and needs to run it by their supervisor. Very important, but never takes the place of regularly scheduled supervision. And lastly, case reviews to ensure consistency in work. We do 100% case reviews in Ventura. Other systems do different models. But so the TRIO is one component of a comprehensive model in APS. The other thing about the TRIO is that it's not an allegation-driven tool, meaning once the referral comes in and an allegation is made and the social worker goes out to confirm or not confirm that allegation, is very important. That's part of the work. But that's not the only thing the social worker looks at. So the TRIO allows the social worker to look at the comprehensive situation and not just the allegation, because oftentimes the allegation is only a piece of the problem, not even the problem, or just a part of the whole system. So the TRIO is what I call kind of the movie. The allegation is the ticket to the movie. It allows us to knock on the door. It gives us authority to enter the home with permission from the client. But once we're in, it gives us an opportunity to do a comprehensive investigation and assessment of the client's situation. And the other thing the TRIO does is it makes this assumption that elder mistreatment, abuse, and neglect is progressive. I can't prove this, but this is the assumption that we work on. And this idea of progressive nature came from this study in 2003 that I'm not going to read to you. But this tome, which is a hallmark piece of work in our field, in one of the recommendations in that tome suggested, not been able to be proven, suggested that elder mistreatment abuse looks like it follows a similar path of a disease. Not that it is a disease, but that it has periods of stability, tipping points where there is sudden or slow decline, and that there are opportunities to intervene. So we design the TRIO. When I show you, you'll see that we assume that abuse and neglect is progressive in nature, gets worse over time if we don't have the correct intervention, or the client doesn't allow us to intervene, or whatever the case may be, that it will get worse over time. Let me just pause for a moment, Andy. Is there a question to this point?
I believe there's only one real question that we have so far, Linda, and that was do you have any more information about what the MoCA is? I believe that's a tool, isn't it?
Yeah. So the MoCA is the Montreal Cognitive Assessment. It's probably preferential to the MMSE because what the research shows is that the MoCA is more sensitive to our population than the MMSE, but any tool that's used to assess cognitive impairment is probably a good thing. We use the MoCA and the instrumental activities of daily living on every client 65 and older. Okay.
Interesting.
Okay. Yeah, so we're trying to link now to the TRIO.
Okay. Sure.
So we're having a little so Eddie here is working.
We have one other question,
Okay.
Linda, while we're waiting, if you like.
Sure.
Are there laws legislating how you do this work in the States? So I guess that's a question about California's law and how it fits in with the TRIO. Did that have anything to do with?
No.
No.
No. No.
So it can be used anywhere, sounds like.
Yes. So the TRIO that I'm going to show you, or I hope that I can show you, you can access yourself. So at the end of the PowerPoint, I'll give you the link to the TRIO so that you can go in and play around with it and see it.
Okay.
Okay, so Eddie has to, that's the welfare to work. No.
And Linda, is the TRIO, is this a paid, is there a cost involved with using it, or is this a free service?
Yeah, that's it. Yeah, so the TRIO, there's no cost to using the TRIO. The data that is maintained in the TRIO, right now we have over 9,000 episodes in our TRIO. Let me just do this, hang on.
Sure, go ahead. And there's a desk manual that comes with it, and training is all free. It's hosted by a national company that is known nationwide for their public administrator, public guardian. Lots of states use the Panoramic PAPG. They're the ones who took our paper form of the TRIO and designed it into the electronic form. So they host the data. They charge a slight hosting fee. Gotcha.
Okay, so I'm going to open the TRIO. So you can see the TRIO is an unusual looking tool. It's in the shape of a curve because we believe that it's progressive in nature. So we're looking at the progressive nature and then working up towards the protective outcomes. When we went to turn this into an electronic version, we asked the social workers, do you want a checklist or what do you want? They really wanted the graphic design of the curve. This graphic visual just seems to work for social workers and how they view their work. So the left side of the curve is the risk side. This is documented in real time after you see the client. We don't use the TRIO with the clients because it's a barrier to building rapport. The right side is completed at the end of the case. That's how social workers work. If you demand that they document the right side at real time, they just won't do it. The left side is done in real time, otherwise they're not picking up or remembering things that they should be remembering. We have iPads, so they can do it after the work. They can do it on their desk, and the social workers are really quite good at documenting in real time. So the first set of risk indicators we call precursors because these are risk indicators that do not confirm abuse or neglect, but these are those elements which make our clients vulnerable. The left side of the curve came from a study by UC Berkeley. They did an investigation on what are the tools, what are the risk indicators in our field. They published this paper. We used most, if not all, of their risk indicators. Those that we were not selecting, we just dropped off the tool. So here's the precursors, and all the social worker does is just click select. And for consistency, if you're not sure what something is, there's a definition there. If you don't have definitions and people are not trained, they'll just think what it is. And so you can't have consistency if people just make up their own definition. We also have a desk manual that many of our social workers keep kind of right at their fingertips. So if they want to look up something, they can just brief through pages. It is not uncommon to have an unfounded, meaning there's no risk, but have a cluster of precursors. That was not unusual in our population. So now we go into the established social work practice as we look at the biological factors. And these are in order of what we think is less severe to more severe. So underweight and frail is a serious risk indicator, but it pales if you have presence of dehydration or decubitus ulcer. So we attempted to put them in order kind of severity, but once again, we don't look at individual items, we're looking at how they cluster. And this is how quickly it works on any. We go into our psychological indicators, once again, self-blame. I'll talk about self-blame in a minute. More benign than hoarding. And the hoarding definition is based on the new DSM-5. We can update these definitions at any time if the industry changes.
Linda, one question. We're not seeing anything. We're still seeing the curve.
We're not seeing the.
Yeah, we can only see where it says. And I was waiting a second to see if we should be seeing more, but we had a few questions about it, so I think others are having problems too. But yeah, we just see the curve part, the Adult Protective Services tool for risk.
So when I click on precursors, you don't see the.
Let's see. No, it seems to be kind of frozen out. And yeah, other people are saying the same thing.
Hang on a second. What?
Sure.
They can't see the internal.
We only see that very first screen that came up.
Oh, I'm sorry about that. Oh,
that's okay.
This worked
That's why
before.
we're here to troubleshoot.
Well, I don't know. Can we do something about that? Yeah, we can't fix that.
Do you want me to take the screen back for just a second and then give it back to you? Should we try that and see if that works?
Do you want to try that, Eddie?
Here.
Okay, why don't you try that?
Okay, all right, bear with us, folks, for just a minute. We just do a little bit of technical troubleshooting here, all right? All right, Linda, I'm going to make you the presenter again. I took the screen back, but now I'm giving it back to you. Let's see if that fixes anything.
Okay, let's try it.
So you should get that same pop-up. There you go. And now I see your mouse moving around a little bit, so maybe it'll work this time.
I go back.
We still see the curve.
Okay, so let's try again. Okay, it's saying for some, please move this to resume screen share. Let's try this. Let's go back.
Now it looks like we have a blue box.
Okay. Do you see precursors?
No, we just see a blue box.
Oh, man.
I believe.
Okay. Well, you can access this. I'll give you the access to the demo. I don't know what the problem is, but under each of these indicators, there's a list of components. So like under psychological, it begins with self-blame, feelings of shame, anxious, clingy, to hoarding. I apologize.
That's okay. No, that's okay. If we can give folks access later on after the webinar to peruse themselves.
Yeah. Okay. So I'm going to release. Let me see if you can see this.
Okay. We just see a blue screen right now for some reason, like a blue.
That's all you see is a blue screen. Okay. So at the end of the trio, it prints out a summary report, which is a documentation of all the work that's been done on that case and documented in the trio. I just can't show it to you, so I apologize.
That's okay. Well, we can send the link out to folks afterwards. They can try it out themselves.
Okay, I need to. Okay. So here's an example. Can you see this? Andy, you there?
I'm still here. All I'm seeing is a blue screen still.
You're just seeing a blue screen?
Yep. Should I take it back and try one more time?
Yeah, take it back.
Okay, give me 1 second. Sorry, folks, bear with us 1 more minute. All right. right, and here, let me give the screen back to you again one more time, see if we can correct it. And maybe that the PowerPoint will be the only thing we can see.
What do you see now?
Let's see, you should have a pop-up box on your screen asking for permission to share your screen. Because right now we're not seeing anything until you...
They don't see anything. Nope.
There we go. Now we see your PowerPoint again.
Okay, so let's try again. Do you see that?
Yeah, we can. TRIO, yeah, Adult Protective Services Tool for Risk Interventions and Outcomes, Psychological Indicators.
Okay, so if you selected psychological indicators, this is what would come up. And when you click on the eye, it gives a definition. So under every item on the TRIO, there's a definition, so that every social worker is selecting something that is accurate and true and agreed upon. I'm disappointed I can't show you that. So the research on this is published in this article, which is open source. If you want access to this, just let me know. You can go to Routledge and download this article. So the TRIO data had the goal to identify who's our population, what do we do, and what we achieve, but most importantly, what is the relationship between the population, what we do, and what we achieve. So in 2009 to 11, we had 2,500 episodes. Right now we have over 9,000 episodes in our database. Most of them were older adults. 50% were confirmed. So the data I'm going to share with you today is focusing on our elder population, 65 and older, with confirmed allegations. That's the only data I'm going to show today. So some of the key findings in our risk indicators was that the clients who were abused by others tended to have higher relevance in these risk indicators: high family and marital conflict, exploitation, and they were alert and oriented times 4 spheres and were able to declare, that's not my signature, my grandson hit me, so they're able to declare. So these were key components or the, of that population. In contrast, you would expect that our self-neglect clients look a little bit different, and they do. They tend to have more items related to hygiene, poor health, and not taking care of themselves and access to medical care. What was really interesting to us, because I've talked to many people who believe that that each client is so unique that it's impossible to measure anything in adult protective services because each situation is so unique. What we found was, of course, there are uniquenesses among people, but what we actually find was that our risk indicators clustered around 10 profiles, and each of those profiles had a different outcome. I'm going to show you some of those. Our next phase of research would be, if we would pursue more research, would be to do more research on these unique profiles. The other finding from our indicators was that there was such diverse clustering in the biopsychosocial and precursors that really brought us to believe and to know that our client situations are quite complex. And that's what highlights the challenges to our system, is that they don't tend to cluster around just biological issues or just social issues or just psychological, but in fact, they have complex interplays among all of those. 70 to 75% of the time, we were able to close an episode by eliminating or reducing the risk factor, and that remains true today. As I run the data in the TRIO, we generally can fix the problem between 70 to 76% of the time. Very interesting. Whether or not the issue is unresolved has very little to do with the allegation type. So we know that financial abuse is very complicated to sort through, but that does not have a higher prevalence of unresolved protective issue than another type. So it's not the allegation that leads us to be able to reduce the protective issue or not. There are other issues involved, and I will show those to you. We find that our elders come back at a higher rate than our dependent adults. We don't know why. What we would conjecture is that we often find that our dependent adults, defined in California as those with mental illness or a physical disability that renders them really incapable of advocating for themselves or protecting themselves, they tend to have more support services or other systems involved in their lives. And that becomes a protective factor. That's what we guess. We're not sure, but that's our conjecture. We also find that it's more common for our clients who have a confirmed allegation to come back with a confirmed allegation 13% of the time than a progression from inconclusive to more serious. What that tells us is that social workers are really good at ascertaining the disposition of the allegation or disposition of the situation. So if they say that this client is inconclusive in California means there's some evidence of abuse or neglect, but not enough to confirm it, but we're concerned about this client. They come back at a less rate than those who have been confirmed. That speaks to really the talent and expertise of social workers. We also found that elders with an unfounded allegation, that we could find no evidence, they progress at a very low rate, 6%, to a more severe allegation. They do come back, but we're really good at making that disposition. We also found in our research that those clients with a precursor of a physical disability or confusion are associated with our ability to resolve the issue. And we're not sure why. We think possibly, once again, that those with physical disabilities have more services or more resources that we can tap into than others, but we're pretty good at that. When it comes to interventions, the kind of the grab bag for most APS systems are these three. And 68% of the time on the trio, we selected providing information education about APS, about their situation, about their prognosis, about services available, referring for services, and working with the client's support system. Not the professional system, but the client's family, neighbors, churches, synagogues, mosques. That is the hallmark of our trade. 10% of the time, they receive other interventions, like, we pay for grab bars, we drive them to appointments, we consult with a medical practitioner, we get a restraining order, we move towards a guardianship through the court system. That's about 10% of the time. Very interesting, 30% of the times of our confirmed self-neglect, we send in an in-home nurse that's on our team. And I can tell you that if we had twice as many nurses, this number would be twice as much, because most of our clients, if not in the allegation, but once we get into the home, have some biological or health issue that if we had a nurse available would be very helpful in mitigating that risk. And then to show kind of internal validity, our confirmed allegations have the highest number of different interventions. You would hope that. That would be intuitive, that if you have a confirmed allegation, that social worker is doing as many interventions as possible and appropriate to mitigate that risk. You would hope for that, and that's what our research found. This slide is really interesting. This slide speaks to the importance of measuring progress to goal. So we measure not only did we fix the problem or mitigate the risk, but we also measure, was there any improvement in health, safety, and financial? We define that as, did we slow the rate of decline? Did we stave off the problem? And did we move them to a higher level of life situation? That's how we measure that. you can see what we're really good at is improving safety and stability. And that's probably because we have a lot of resources within APS at our fingertips to provide safety and stability within their home and in their environment. The next one is health, which is 25% of our population. That might be higher if we have more control over our partners, because we rely on the healthcare system, our behavioral health system, doctors, the private sector, the public sector to provide services. And whether or not they will or can, like for example, in Ventura County, to get in the mental health system, you have to have a severe mental health diagnosis. Many of our clients don't rise to that. They have debilitating depression, debilitating trauma, debilitating anxiety, but that does not meet the criteria for severe mental illness. And then finally, financial security. Some states out there might have a higher number if you keep your cases open longer. So in California, we tend to close our cases within 90 days. We're considered a short-term case management. So oftentimes the improvement or stability in their finances happens after we close the case, and we might not know what happened. So a case gets referred to the DA, it gets prosecuted, there's restitution back, we might not know about that. So this slide speaks to the importance of measuring progress, client improvement, as well as whether or not we fix the problem. This slide is very interesting to us and actually changed our practice in Ventura. This slide speaks to who comes back as it relates to who the social worker thought would come back by age and gender. So very interesting. We always thought that the 80 plus were a much higher risk and would come back at a much higher rate than our younger elders, not proven to be true in our research. No significant difference in recurrence between those populations. And interesting enough, our younger elders are more likely to have an unresolved protective issue than our older ones. We're not sure why. We think, we conjecture, that the 80 plus have lived a long time. They have a lot of resilience. They also may have some awareness that they need help. So we're much more successful with that population than with the younger elders. I'd be curious as to other systems, but true for us. And males don't do any better than females, vice versa. But interesting enough, our younger elders used to get a better prognosis. We used to say, they're not going to come back, or they're unlikely to come back, but there's no connection between that and the actual recurrence. So that really changed our practice and our bias towards 80 plus and our bias towards 65 and 79. So before I go into engagement, any questions at this point?
I think there was one question ways back, Linda, about persons with disabilities, possibly younger adults with disabilities. Yeah. I think you touched on that a little bit. Is there anything else you'd like to say about the difference between the elder population and that population of younger adults with disabilities?
We tend to be more successful. We tend to be more successful with the 18 to 64 dependent adults, because oftentimes they already have systems in place that need to be re-engaged or restarted, or a new case manager or something. Mm-hmm. Yeah.
Gotcha. Great.
So, anything else?
Go ahead. Go ahead.
Okay. So this next one is about engagement, and this is probably one of the most important slides. And you're going to go, well, so what's new? We already knew that. So sometimes the importance of research is just to confirm what we intuitively know. And that's what this part of the research showed. We intuitively know that clients who engage with us probably do better than clients who don't, and the research has borne that out. So what David Sommerfeld did was he used a statistical analysis called latent class analysis. What that does is you're not pushing for a particular outcome, you just throw the data into this analytical tool and see how it falls out. That's what LCA is. And what we found out is that our clients, we're talking about elders now, basically fall into two groups. Those who accept extensive interventions from those, and those who accept limited engagement from us. Obviously, those who accept more have better outcomes. That's kind of a no-brainer, but the research bears that out. What that does in practice, though, is that knowing when to close the case is very important. We don't want to close the case too soon because we want to attempt to keep engaging, and we don't want to keep the case open longer than what is appropriate. In Ventura, we do kind of a 3 knocks on the door before we leave. We try to get into that house. We don't take no for an answer. We're very, very persistent. That persistence really pays off. Trying to get into the home, using many strategies to get into that home pays off. That's why this research is important. Trying many, many different interventions, maybe using a different social worker, bringing it to an MDT is very essential in that extensive engagement. Lower participation was a strong predictor of an unresolved protective for our self-neglectors and abuse by others. That population is a high-risk population, and I'm going to show that. And building rapport, trust, bonding increases the likelihood of better outcome. That is established social work practice that's taught on day 1 in any MSW school. Of building rapport, trust, and bonding with the client leads to a better outcome because we have found that many of our clients have a history of trauma, so engagement is very frightening to our clients. Oh, see, I'm not going to be able to. Can you see this slide?
Yeah, we can see that slide.
Okay.
Client engagement, yes.
Okay. It's pausing. I'm getting these odd. I'm sorry, I'm talking to my IT guy. I'm getting these odd prompts.
Okay. Yeah, I don't think we're seeing those.
Let's go back.
We see the summary of key findings slide right now.
Okay. Nope, no video. Okay. So, what I want to show on this slide, do you guys see a blinking, anything blinking on your slide?
No, we just see summary of key findings. It's a
okay.
PowerPoint slide.
And data, right?
I don't see any data.
You see the chart?
No, we don't see
my
chart.
Goodness, my goodness. We're having a problem on this screen sharing.
Yeah, we only see the PowerPoint slide that says summary of key findings, and it ends with abuse by other, family conflict, shame/guilt.
So for some reason, it's pausing the screen sharing, which is not allowing you to see some of these slides. And we tested
may need to share your whole screen instead of just the PowerPoint. It looks like you're just sharing the PowerPoint application. You may want to share your entire screen. That might be the issue. That's one thing we could try, and that would be in the GoToWebinar control panel.
Okay, so as Eddie is working on this, is what we have found in our research that self-neglect clients, abuse by other clients, and self-neglect and abuse by others have different profiles. They look different and they have different outcomes. Let's see if Eddie's getting something here. Keep going back.
Was it back?
Yep. Here. Can you see the chart now?
Yeah, we can see prevalence of common risk factors and outcomes by confirmed allegation type.
But do you see the chart?
Yes, we do.
Do you see the numbers?
Yep, we do.
Oh, okay. Maybe I can go back and show the trio at some point. So what this data shows is that these populations look different. So let me orient you to. So we have some risk factors on the left, and on the right is the significance, because you want to know, are these differences just random, or is there statistical significance? And so we have 1 out of 1,000 chance that these differences is random. So this is a pretty good difference between these populations. So what you see is that that self-neglect, lives alone, underweight and frail, are key components, as well as history of referrals. When you look at your abuse by others, they look a little bit different. They have high rates of marital conflict, exploitation. When you look at our combined, they have strong lives alone, underweight, frail, conflict. But let's look at the outcomes. If you look at the unresolved protective outcome, they're about the same. This is why the allegation alone is not a predictor in particular. So even though the self-neglects tend to have a little bit higher rate of an unprotected issue, statistically they're about the same. But let's look at who comes back. And we used a 180-day recurrence rate. In California, we actually use a 12-month, but what our research showed is that if people come back, the higher risk time for people coming back is within that first 6 months. So if you had a longer-term case management model, which we don't, but if you had one, that's when the most critical time is that first 6 months. So the people who come back are the ones who have both self-neglect and abuse by others. That is the highest risk population based on our research. Refusing help and APS history are global risk factors across. Let me define refusing help. Refusing help is not that they're refusing you. Refusing help are those clients that you go in and you say, how about we get you Meals on Wheels? No, thank you. How about we bring in someone to help with such and such? No, thank you. These are people who have a lifelong characterological approach to life where they don't want help from anybody. That population has a very low risk of being able to resolve the protective issue. Other specific risk factors specific to an allegation in self-neglect or lack of social support, confusion, and abuse by others, those two. We tend to look on the trio at clusters, not individual items. But I can tell you, as a standalone, lack social support is the individual risk item most significantly related to clients coming back. I think that's standard in the literature about social support and getting older. So they fell into these profiles. Let me just show you a little bit. They fell into 4 self-neglect profiles. This first profile, this hygiene, poor decision, has the highest recurrence rate of those self-neglect, and that's because in that profile we have hoarding in that profile. This number 4, the 57% diffuse, relatively new. Diffuse means they have a smattering of risk indicators throughout the trio. I'm going to focus on this abuse by other profiles, 5, 6, 7, and 8, because there are states still that don't recognize self-neglect, although some states are coming online with that and adding that to your legislation. But I'm going to focus on abuse by other risk profiles. So let's take a look at these confirmed abuse by others. So profile 5 is mostly confusion and frail. And look at the difference between these 4. These are all confirmed abuse by others, but look how different they look. This speaks to the importance of being able to understand the situation, triaging what's most important, and selecting the right intervention. So this profile number 5 has a high cluster of alcohol, frail, compared to the others. So look, if you look at profile 5, an unclean, unsafe 33% compared to the next one, which is exploitation and money issues, 1.5. But look at the high rate of a history of APS referrals in profile 5. My speech here is referrals to APS in history is one of the most important risk indicators to take attention to. There are systems that will look at a referral that comes in within 6 months or 8 months and says, you know, we were just out there, not much has changed. would challenge that based on the research, that a lot has changed. If you believe that we do, that elder mistreatment and abuse is progressive in nature, lots change. So this history of APS referral is very, very important. So profile 5, this is our confusion, kind of frail. This is what they look like. Our exploitation financial, very high in money. You would expect that. That speaks to internal validity. You would expect that a profile on the risk side that is identifying money and exploitations will show that. Then we have our high conflict psychological. These are able to be able to declare abuse. And then our profile 8, which is this new to APS, diverse, smattering of risk indicators, but very high declaration. This is probably why we're very successful with that population, is because they make good witnesses in court, because they're alert and oriented times 4, and they can make a declaration. So let's see, how do these profiles do in client outcomes? So we do pretty well in our exploitation with money. You would hope to see that. We do. We do pretty well on health for our confusion, frail, and our high psychological. That's good to see. Very high when it comes to safety. But look at the unresolved protective issue. The fact that the significance level is 5 out of 100, happening by chance. So there is a difference. Each of these profiles looks different. They have a different client outcome, and they look different when it comes to the unprotected. This high conflict in the family, marital stress, high psychological, and I can tell you some more things about that. They have high blame, high passivity, high anxiety, high levels of poor judgment. They are high risk for an unprotected issue. And I think social workers would say when they walk into a situation where you've got generations of internal squabbling, siblings fighting, people fighting, very difficult to intervene in a short amount of time. So our summary is that we have different profiles that have different outcomes, and they look different. So our financial, more likely to have a financial outcome. Family conflict profiles, more likely to have an unresolved protective issue. And while not statistically significant in terms of recurrence, it tends to be, you could say from a practice point of view, these more complex cases come back at a higher rate. So now I'm going to talk about engagement. So I'm going to take this one profile. This is our exploitation profile, and they fall into two groups. High engagement, low engagement. 6A, very high level participation. They bonded, they accepted there was a problem. I won't read the slide to you. Versus the other side of this profile, fairly low. 8% accepted that there was a problem. Very difficult to intervene if the client doesn't see that there's a problem. Look at the low level of bonding. This is a population that's hard to bond with. Lots of reasons for that. Could be history of trauma, other things.
Linda, can I ask one question real quick?
Yes.
You have the LCA acronym in a few different slides, and what does that stand for again?
Okay, the LCA is an analytical statistical tool that researchers use to analyze data. It's called latent class analysis. And what that does, latent class analysis, is a very high-level, sophisticated analytical approach to looking at data, which is you just take your data and you put it into the model, and how it falls, it falls. What David Sommerfeld says, the data speaks for itself. We don't push the data to one side to the other. We don't say, hey, we want to know this, and then force it into that inquiry. We just say, here's the data, what does it show? And so, yeah.
Thank you.
So now we want to look at what is the client outcome when it comes to highly engaged or low engaged. So highly engaged, high finance, high health, high safety, those two statistically significant. But when it looks at 180-day recurrence, they both kind of come back at the same amount because there's no statistical. So there's other things going on besides just engagement. You have to look at the risk indicators, you have to look at engagement, you have to look at the interventions accepted and tried. So overall, those highly engaged come back, and this speaks to the practice issue of working that case to the bone till you hit the T in the road and you can't go any further. Knowing when to close the case is essential to good social work practice. When to keep going, when to push, when to back off, when to close the case. And I can tell you that I think some of the success that we see in these difficult cases is that we have integrated nurses, we have an integrated neuropsychologist, and we have 2 MDTs that meet regularly twice a month. If you have an MDT that meets only when you think you have to, it will not be as effective than an MDT that meets regularly. And we share TRIO with them. Having a TRIO and showing the summary report out of the TRIO has increased our credibility and increased our standing in the community, and has brought in more money from our Board of Supervisors because we share our outcomes with our funders. This slide is a bit tedious. You can look at it later. I'm not going to spend time on it. But what this slide tells you is there is a clear difference in profile between your self-neglectors and your financial abuse clients. I don't want to spend a lot of time, but it has high significance on how different they look, but I'm going to move past it. The other thing that the TRIO does is when we close the case, the TRIO selects a prognosis on what they think is going to happen to this case when they walk away. Every social worker, when they close a case, is thinking in their head, I'm going to see this client again, or I feel pretty good about this. It's very important for social workers to document their prognosis, because if they don't document their prognosis, you're going to contaminate the protective outcome finding, because anxiety will creep into that. You don't want to do that. Prognosis is very, very good when it comes to knowing which client needs long-term case management and which ones don't. If we had long-term case management just based on prognosis, we would know where to spend money and resources. And let me show you how good social workers are at deciding who comes back. This is a 100-day prognosis. What this slide tells you is when the social worker says, very poor, this client's going to come back, they come back. They come back at a 25% rate, versus when the social worker says, this is very good. I think this client is in good stead. I think they're going to stick to the plan. We have good support systems. I think very good. They're not going to come back. And they don't. They come back at a rate of 1.3%. Social workers are very good at this. Given the opportunity to document prognosis, very essential. Every social worker is trained to do this in MSW school. And it's not just based on risks and interventions. It's based on what do we know about the situation? What do we know about domestic violence? What do we know about alcoholism? What do we know about trauma? What do we know about the relationship between this 80-year-old woman and her 40-year-old daughter that she's been enabling for her whole life? What are the chances that she will actually stick to the restraining order? So prognosis is essential. So I want to show you this. This slide comes out of the TRIO. The TRIO measures outcomes. This comes out of the data. So I pulled the data since 2011 to now. There are 6,000 episodes. I'm only looking at confirmed. So what this slide tells us, and this is the data that I give to my boss, this is the slide that I share with my MDTs, this is the slide I give to my Board of Supervisors, this is the slide that we use to kind of see how we're doing. So the first column shows if we only have a social worker on a case, we can fix the problem 74% of the time. If I have a social worker and a nurse, I can do it 81% of the time. Now move to the next slide, because those are our routine cases. Our very difficult cases that come to an MDT, if I bring a case, or I don't bring a case, if my social workers bring a case to our MDT, which we call the Rapid Response Team, we can fix the problem 77% of the time. If I bring it to my FAST, we fix it 83% of the time. But I caution you, that number is only an N equals 18. So that number really is too low to really extrapolate anything out of it. You really need higher numbers, over 30, to say that's a good number. But our FAST is pretty effective. But our MDT is much more effective. Now we have the ability to do a chi-square. A chi-square is a statistical analysis that you can do. You can buy a free service to do this, to say, okay, are these numbers happening by random? Or is there true differences? And what we find is these are true differences. It's 1 out of a 100 chance that this is random. Now, the TRIO can't do a chi-square for you, but you can do a chi-square. You know, you might have someone in your team who can do that, and you can buy a program called SAS and do that. So we know statistically there is a difference between these intervention models. This is very important to our system, very important to APS. This chart alone allowed me to hire more nurses than I've ever had in the past 10 years, and allowed me to add more social workers to my team than we've ever had in the last 15 years in our history. Measuring outcomes has been very important. So overall, the TRIO contributes to our overall strategy, because what we're trying to do is the right intervention, right time for the right client at the right reason. So the TRIO has really helped us with that. This is how you access that TRIO that I couldn't show you, and I might have time now to go back, because I think we might have fixed the problem if you'd like me to. And Andy will post this PowerPoint on the APSA website so you can go back and look at things if you've missed something. You can email me. So many thanks to all these people. This is how you contact us. If you have questions about statistical analysis, you want to contact David. Any other issues about our practice, about the TRIO, you can contact me. Let's see if I have anything else. Okay, so maybe you want that. Andy, should I go back to the TRIO and try again?
Yeah, if you'd like to. If you're sharing your entire screen now, I think it probably work.
Let me see if it works. Because
we also have some questions, so
okay.
you can take those as well.
Go ahead. Why don't you ask questions while I try to pull this screen up?
Okay, yeah, let's go through a couple of those at least. Do you know of any plans to use the identified profiles to identify clients within the aging network prior to the need for protective services?
Ah, very good. Probably not, because it doesn't really describe people coming in. It describes who we have. And really, that is really nascent work. We really need to do more research on those profiles. So what we were able to do, we were able to identify that they actually fall into these profiles, and those profiles have different outcomes. But the data is so rich that I really should go after a grant to do more data to really answer that question, which is an excellent, excellent question. But you won't know until after you go in and see the clients and how the clusters form to know what you have. Thank you for that question. Andy?
Sure. There's another one that asks, are all of your workers BSW or MSWs? Do they have other than social work degrees as well?
We try to hire BS and above. We have some who have MSWs, and we have a couple social workers who have probably been with us a long time. And actually, when we started the TRIO, this is brand new to everybody. It was an idea, and I can tell you my social workers were not jumping up and down about it, because it's like, oh my God, more work, oh my God, more this, more that. And the group that I was afraid of was the group that had been here 10,000 years and been doing this forever. But what we found is we implemented a change management strategy to allow input and feedback, questions, and just practice. We practiced with the tool for a year before we actually went into full force, because we wanted to gain buy-in. And at this point, the social workers would not give up the TRIO for anything, because what it has done for us is the TRIO really started as a tool, and it's ended up really as a model for how we work. So let me ask you, I'm trying to, do you see a list of oh, very good.
Yep.
Any other questions? Oh, very good. Any other questions?
Why don't we look at your demo for now? We can go back to questions.
Okay. So this is what the curve looks like. It's shaped into a curve because we believe that it's progressive. And it's really based on, if anyone knows anything in addictions, it's based on the Jelinek curve. Jelinek was a doctor who first codified alcoholism as a disease. He codified it in a curve. So, wow, this is a good idea. So we used a curve. And you'll notice it's not based on points. It's not based on high and low, because social workers already know what they have when they select something. They don't need to identify it any other way. And if they select it as high or low, well, they already know that. So why go through that? Why go through that extra step? So precursors, those lists of situations that make people vulnerable, but not necessarily confirmed. So we find in our unfounded population often a cluster, we call it a cluster of precursors. And you can select, unselect, and what adds to the consistency and allows us to believe in our data is that every single has a definition. So when a social worker selects it, they're selecting it with fidelity to the definition. Otherwise, you can't measure anything. They also have a desk manual, a written desk manual next to them that they can flip through. And we try to put these in order of more benign to more severe. So history of referral actually is really less benign than you would think, but it is more benign than evidence of high-risk behavior, which is wandering around at night, leaving the gas on, sleeping with doors open, giving away money, driving without a license, etc. The biological, so this is how social workers think. They think in precursors biocycle. Once again, although underweight and frail is very serious, if you have that and presence of decubitus ulcers, this needs a call to 911. People die of this all the time. So this is more severe than underweight and frail. But it's how the cluster looks. So I can change the profile of this client just based on, you know, if I had that profile is much riskier than the profile that I had before. So it's how it clusters and what the profile looks leads the social worker to know how quickly they intervene and what interventions they're going to require. And here's our social. Once again, more benign to the most severe. So if you have someone who's oriented times 4 and says, that's not my signature, my grandson hit me, and they make a great witness, that's more severe than a poorly maintained animal. However, once again, it's just all how it clusters. We also like the specificity. So instead of just having one category of finance, we like to specify. Is it, you know, they're being taken advantage of, they're being charged $25,000 to put in a door handle? Are they misusing their money? Are they overpaying? Because you would define your interventions based on that particular risk indicator. Our triage intervention, that's the emergency room. The left side is done in real time. The right side is done when they close the case. Most of my social workers document the right side in real time because they like working up the curve. It motivates them. So this is the 911. This is the emergency room. If you have call 911 for safety. The interventions are established social work practice interventions across the board. Some are particular to APS, and most are just generic evidence-based social work practice. We start with the most benign, which is accepting education, and the most intrusive, which is taking away someone's rights. We make a difference between referring someone, which is what I call the cold handoff, names, numbers, versus linking, which is driving someone to a service. Sitting with them on the phone and calling the doctor and making an appointment and seeing that they actually do it. So linking has an implied outcome. This is where we measure our client outcomes, and they're all defined. And we covered every possible thing we could possibly think about in financial stability. I can add to definitions. We don't change the categories, but some systems that have used the TRIO say, you know, we actually do such and such. I can add that to the definition to make it more real for them. So each of these is defined. We try to make it as comprehensive as possible so we have more clarity and certainty for people. We also measure this. So you have some clients who say yes to everything. You have some clients who say, well, I'll do this, but I won't do that. And then we have clients who say, no, thank you to everything the social worker offers. And then here is where your data is kept. This is where we choose the protective outcome. Did we eliminate it? Did we reduce it? Is it unresolved? These have very strict definitions, so everyone chooses this, the same one with fidelity to it. And then this is the prognosis. And then you save changes. But I want to show you this because this is the way cool thing that has made a big difference in terms of credibility. So there's no secrets on what we do and how we do it. You can print out a summary of the whole case. So if the case comes back, the social worker can quickly look at what were the precursors at that time, the biopsychosocial, what outcomes, what interventions did we try, what were the allegations, etc. So it's kind of a snapshot of that episode. In this one, we reduced it. The prognosis is fair. So this is me, of course. So someone said, you know, we were able to make her a little bit safer, but her prognosis is kind of fair because we couldn't do everything. She didn't accept everything. There's other issues that we're concerned about. Any questions about that? So this is the demo. So you guys can go into this and play around with it. You can play. These are all fictitious names.
And there was another question again, Linda. I think you may have answered this already, but
okay.
Someone's asking what the cost is again,
okay.
And how long does it take to implement?
Okay, so there's no charge for using the TRIO. There's no charge for your data. All the data that's stored in the TRIO is discrete to you. No one else can see it, and it's yours, your data. You don't have to pay for it. There is a hosting fee. We designed the TRIO in paper form, and we used the paper form for about a year while we tested the model. We then used county funds, and we put out an RFP to see who could create this TRIO in electronic version, and Panoramic Software Corporation could do it. You might know their name because they are nationally recognized for their work in public administration, public guardians. They've been in business since 1972. That's their main book of business. So they own the proprietary rights to hosting the data. So they charge a hosting fee, which is really quite inexpensive. Probably for over 100 users or more, the hosting fee is probably about $8,000 to $10,000 a year. That means they respond to any questions about the server. If there are any server issues, which we haven't had any in the years, they can add or delete access, etc.
Okay. Great. And there is a question about how the case notes are documented. Is there a way to document case notes?
So great question. So I think I mentioned that the TRIO is only a part of a comprehensive APS approach. And here it is right here. So the TRIO is only a risk tool and an outcome tool. You need to have a vibrant, wonderful case management system that does everything else.
Right.
It has all the demographics of the client, it does the case notes, it does all your state reporting, etc. The Trio does not meet that. The Trio is not designed for that. And if you have a case management tool, the Trio is a standalone tool. My social workers can document in both. They just toggle back and forth. They just minimize the Trio if they're using their case management tool. So they're standalone tools and discrete data points. So the Trio collects data on the risks, the interventions, and outcomes, but nothing else. No demographics, nothing on the perps, nothing on strengths. I hope I answered that because that was a very good question.
Yeah, yeah. How secure is this data that is entered into Trio?
Yeah. We use Panoramic Software Corporation for our veterans. The state of California uses Panoramic for their statewide veterans program. Like I say, some people listening out there might know Panoramic because they use the PAPG, and there are systems in California that use their APS case management tool. They are HIPAA compliant, highly secure system. But if you want more information about that, I can get that for you.
Yeah, and there were multiple requests. There were multiple requests for you to keep this info up just a little bit longer on the screen so people could jot it down before we got the slides out to them. There is a good, while we're keeping it up for a bit, there was a good question about where do you address the different perpetrator characteristics, if you do?
So we do that in our case management tool.
Okay.
So here's the thing about tools. What people tend to want to do is called creeping elegance. You have a tool and then you keep adding to it until it's so cumbersome nobody wants to use it. So what we wanted to do was we only wanted a tool that identified the risk interventions for the client and the family system, not a perp tool. So our perpetrator information is in our case management system. I mean, we could design a perpetrator tool because all that information is valuable and necessary, and there are some states that actually have alleged perpetrators have rights to appeal confirmed allegations, so you want excellent perpetrator information. But for us, that's in our case management system. This is not a tool for perpetrators.
Gotcha.
Great question. Great question.
Are the social workers that you work with, are there any concerns of duplication of data entry in their work?
Yeah, so one of the goals when we designed the Trio was to avoid duplication of work because it's a waste of time. And you're not going to get buy-in if you're asking social workers to document here and document there. So what we ask of our social workers, they're not required to document any of the risks because it's already there. What they do document is details around the risk, or the evidence they have about why they selected that risk. So let's take, for example, hasn't seen a doctor in over a year. That's on the risk tool. The social work might document that actually the client has a primary care physician, they just haven't gone. So they might want to document the detail in the narration, but they're not documenting the risk indicator was this. And they're not documenting the interventions they're trying. What they're documenting is the client's response to the intervention, the partner response to requests for help for this client. They're documenting the details, but not the items and elements on the Trio. That's a really good question because that's what social workers ask all the time.
Another question is there anything
prohibit?
Anything you can think of that would automatically maybe count somebody out from using Trio?
I don't think so. This is what I would say about anything that we implement new. I find that APS social workers are among the most resistant to change for whatever reason. So if you embark on any change, whether you do a Trio or you do any other model or you change this or change that. You better have a good model for change management. You have to have a structure and a vision for change management. What are the strategies you're going to use, and stick to it? Because what I find, not with the TRIO in particular, what I find with any change management, you know, executives come up with great ideas and managers, we get gung-ho, we throw it out, we get some resistance, and we give up. And so what that teaches workers is, if I just hold my breath long enough, this is going to go away. And that's the responsibility of management. That's our fault. If we have a system that we've created that, then that's our fault. So, because I think change is hard. I mean, APS is a difficult system to work in. We have difficult cases. Andy, you and I were talking about, is child welfare harder or not APS? And because I was the head of child welfare here, I would contend that APS is really a much more difficult system to work in because we don't have the court to back us up.
Right.
We can't knock on the door and say the judge sent me or law enforcement is here. We have to work on rapport, bonding, trust, just who we are, our skills, our innate abilities to convince people to work with us. That is much harder. So I think change is difficult in APS systems. So the only thing I would say is anything you implement, let's say you go, okay, we're going to have a new rule that everyone has to document in their case management system within 5 days. That's our new rule. If you're going to do that, you better have a strong change management strategy to stick to it. Thank you for that question. I appreciated that question.
I think we probably have time for one more question, and that's about it. This one's just a couple sentences long. Since there is no scale, does this tool run the risk of a degree of subjective observations being made by the social worker?
Yeah, so, you know, I think there's subjectivity in anything. You go into a doctor's office and they put a blood pressure cuff on you, and one nurse takes your blood pressure and another one, and they're different. So there's always subjectivity no matter what. What the tool does, it mitigates that subjectivity because, number one, we have agreed upon terminology and that we have fidelity to that. We talk about it all the time. The TRIO has become the foundation by which we do everything in our APS system. You walk through our APS system, you'll hear people using the word TRIO all the time. It has become our model.
Yeah, right.
So there has to be truth to fidelity of definitions. And then we do 100% case review to see if we do have consistency. Sure. Without a TRIO, I was contend you have high subjectivity. So the TRIO or any tool like this brings you closer to standardizing and consistency. That's a good question.
Well, I think we're good at this point because we're coming up to the end of the webinar. I'd like to thank Linda for being here with us and presenting all this excellent information on TRIO. I think everyone learned something from it, and yes, we will be sharing the slides with you for the webinar today, along with the recording of the webinar at the same time. We'll send that out to everyone who registered for the webinar, just not just those who attended today, but everyone who even registered for it. So the people who weren't able to come will also receive that as well, and it will be posted on the NAPSA website and the National Council on Crime and Delinquency website as well. So again, Linda, thank you for being here and doing this for us. We really appreciate it.
You're very welcome. It was my pleasure.
Yeah, and please, everyone, you'll complete your evaluation. When you end the webinar, a very brief evaluation will pop up. So you can complete that for us. There'll also be a link to it in the email that will be sent to you within 24 hours after the close of this webinar. So thank you so much for being here today, and stay tuned for more information about our next webinar. Thanks so much, and thanks again, Linda.
And thank you.
Bye-bye, everyone.
Bye-bye.